Okay, it says I'm recording. You have the, it's all yours, doctor.
All right. Thank you for inviting me for this presentation, giving the overview of one of the most advanced technologies called CyberKnife for the treatment of prostate cancer. So prostate treatment options, we have multiple options, depends on the stage and the risk level of the prostate cancer. You can go through the active surveillance if it is a low risk, for example, prostate cancer, or very low risk prostate cancer, or surgery. You have option of radiation treatment, which there are multiple types of radiation treatment, including external beam radiation treatment, a brachytherapy treatment, which is the internal radiation treatment. The oldest technology, which is used low dose rate brachytherapy with the iodine seeds, or high dose rate brachytherapy, which is a newer technology and radiation treatment from inside. And then you have CyberKnife, which is other names for it is stereotactic ablative body radiotherapy, SABR, SBRT, radiosurgery. This is one of the most advanced technology, most recent technology that we have been using for prostate cancer. Also, the other ones that, again, we forgot to mention is proton therapy. Again, I was the director of the proton therapy as well. And I can, again, go over all of these very briefly and what are the benefits and advantages and disadvantages are. Other local modalities that are out there is HIFU and cryotherapy and etc. Again, those are not based on level 1 evidence, but they are out there. And also there is hormones and systemic agents that are used for high-risk prostate cancer or metastatic levels. Now, just a very small overview, a very short overview of the prostate gland in the human body is literally the size of a walnut, but every person has a different size of it, and due to as patient ages, the size can increases due to benign prostatic hypertrophy. The function of it is the exocrine gland of the male reproductive system produces a component of the seminal fluid. And that's the shape of when after the surgery, if a surgeon take a prostate out, that's the shape of it. And this is the human body, this is the bladder, and this is seminal vesicle, and the prostate is a little thing over here, okay? Now, we want to move toward the types of radiation treatment. What are the types of radiation treatments out there, and what is the difference between CyberKnife? What is the benefit of it, right? So one of the oldest technique that was being used for treatment of prostate cancer is still being used is internal radiation. What it is, we are radiating the prostate cancer from the inside of the body, in versus radiation from outside coming in. So in order to do that, the oldest technology was to put radioactive seeds inside the prostate. So you would take the patient into the surgery, into the operating room, and we put the ultrasound into the rectum and looking at the prostate gland. And based on that, we would put needles inside different sections of the prostate, and we would drop radioactive seeds. In this case, would be, for example, iodine-1, seeds, radioactive iodine seeds. And this is, for example, iodine-125 seeds. Again, it looks big in the picture because we zoomed in, but in reality, it's only about a half centimeter seeds that we put in, and I'll show you more in a minute. And again, we put these seeds into the prostate, and this will be in there for the rest of your life. And they would emit radiation to kill the prostate cancer, and over time, the radiation would go out and go to zero. And this is, for example, an overview of how it was done. And still, again, some of the centers, they still use this technology and this old technology to place the seeds inside the prostate. So this is a template, and they will put the seeds inside the prostate, but needles inside the prostate in the operating room. So it's an invasive technique. It will be a little bit painful, but you will be under anesthesia. But again, afterward, it's invasive, and the seed stays in the prostate. So after the seeds are placed, if you take an X-ray, you see multiple seeds. You see multiple seeds are inside the prostate, and that's what it looks like. There's an X-ray of the prostate seeds that the patient was taken, and this is what it looks like. As you see, it's very small seeds. It's not that big. That picture, the previous picture, was a zoomed-in picture, right? So now the technology got advanced and went into the brachytherapy, which is called high-dose rate brachytherapy. And what it is we're using a different type of radiation source, radioactive source, that is much stronger. So we don't have to actually put the seeds inside the prostate for the rest of your life to kill the cancer cell over, you know, a long period of time. Is actually we can radiate the prostate from inside out by putting that seed into the needles that we place into the prostate. So again, we take the patient into the operating room, we put the template, and we put the prostate needles, pretty much is large needles that goes into the prostate. And if you look at these needles, there is in the middle of each needle, there's a hole that goes into the prostate. So there's a sterile hole, there's an empty hollow needles. And what it is after this is done, we put the patient on pain management, and we bring this patient down into our department, and we'll connect it to a machine that feeds radioactive seed into these needles, and for about 5 to 10 minutes, and then removes it, and that's all it is. There's no placement of the seed inside the prostate. But again, there is the only caveat of this is it still is invasive. So this is the machine that feeds the radioactive seeds inside those hollow needles. And that's what we use nowadays. This is the modern, if we do brachytherapy, this is what we use. It's called brachytherapy after loader. And this is another picture of it that, again, the radiation seeds goes through those, and we connect these attachments to the end of those needles that I show you, and it goes inside the body and it comes back out. That's all it is, like a train. When we plan it, we actually plan it very live. So we have an ultrasound in there. We know where the needles are, which is all these greens are the needles that we assigned. And this is pre-planning before we go to the surgery to put the needles, to get a beautiful, nice plan. And then we know where to put the needles when we are at the surgery. So when we go to the surgery, we have that plan and we press the needles in, and this computer technology and the planning system tells us exactly where we're putting the needle and it is in the right place or not. And this is another picture of it. As you see, these are the needles are placed. The green ones are the needles, as you see. It looks pretty bright because they're metals. And this is what it looks like in the operating room when we place them inside the prostate. And then the patient comes to our department, and we attach them to that afterloader machine that we showed you that feeds the radioactive material inside the these hollow needles inside the prostate. So pretty much radiate the prostate from inside out, right? So internal radiation. So now, other techniques, again, the only caveat of this internal radiation is very invasive. So we put needles inside your prostate, multiple needles is pretty invasive, pretty painful. So then the other techniques are that it was the evolution of external beam radiation treatment. So the radiation coming from outside. You know, in the past, that technique was not advanced, but over the last 30, 20 years, it was advanced significantly. Okay, and that's why majority of the patient now gets external beam. So it means the radiation coming from outside. So the initial technique was two-dimensional technique. It was in the era of there was no CT scan, and we would just take an X-ray and we would say, this is the bladder, this is the prostate. We're gonna blast through from your belly down and from your back toward your belly. So pretty much two beams, and we would blast through and catch the prostate and anything around it. And it was a lot of toxic. It was causing a lot of toxicity and morbidity. And then later on, it advances to something called three-dimensional radiation treatment. And that's when the CT scan emerges. So when we have a CT scan, you can actually know where the prostate is, know where the hip is, know where the bladder is. So then we started putting more than two beams, so 4 beams, for example, here. And you see still at that time, which was 30 years ago, probably, we still would blast through the hip, and we would blast through the bladder and the rectum, and the conformality was still low. It means the radiation dose still would be leak out to the other areas or adjacent organs around it. So then there was an evolution of three-dimensional to IMRT, which is intensity modulated radiation treatment. And now we're going to the ARC, which is the arc therapy, which is using radiation all around the body. So this is a three-dimensional, and I'm sorry, this is the three-dimensional, and then this is we're using MLC, which is the new technology that can shape the beam toward your prostate. And this is what you get when you get IMRT or arc therapy, very advanced conformal treatment with lowest amount of dose to the adjacent critical normal structures. But moving forward, also something else emerges within the last 5 to 10 years. I couldn't find where to put this, but I put it over here. is something called hydrogel, because one of the toxicity we get from radiation treatment from outside to in or from inside out is rectal toxicity. So diarrhea is one of the toxicity you can get. And in order to decrease that toxicity, there is a new technology, which is called hydrogel rectal spacer. What it is a gel type of situation that we push and we inject between the prostate and the rectum, and it separates the prostate from the rectum, so there's not much radiation to the rectal wall. It decreases the radiation amount to the rectal wall. And the beauty of this gel is, over time, this gel absorbs into the body. So it doesn't stay with you. Like, for example, if the bottom of side, this is a pre-implant, and then we added the implant, the spacer, which is the gel. 12 months later, the spacer is gone. So it's perfect for our situation. We put it in, we treat the patient, and later on it will absorb. So let's go move forward at what happened during all of this advancing technologies and evolution with IMRT, with conformal radiation treatment, is one of the technique and programs software got also advanced as well into something called dose volume histogram. This is a technique that we can know how much dose the target or the tumor is getting, and how much the adjacent critical structures around it is getting, and how much can we have the freedom to push the dose up. And that actually helped radiation oncologists and to improve the outcome of treating prostate cancer, because we actually know what the constraints are, how much we can push it, how much we can push, and what is the local control is, and what is the toxicity is. So after the emerge of this technology or this software advancement with the conformal radiation, it was about 20% increase in biochemical control rate that we saw if you look at the old publications. And this is what is a modern linear accelerated looks like when it gives you the very conformal radiation treatment, which we do have it in our place as well, in our center as well. This is what is used in more than 90% of the centers around the country. This is another picture of it. We can treat not just prostate, any other type of places of the body and sites or tumors. Okay. Now it comes to CyberKnife. What is the difference between CyberKnife and that? And the beauty of that, as you see, it looks different. It has an arm. This is the same arm is being used in manufacturing cars. This arm is very sensitive, precise, within millimeter, and this make the top of the arm is a linear accelerator which produces radiation. The arm allows the unlimited freedom of beams that goes around the patient and causes the very precise, accurate, conformal radiation treatment. And what is the benefit of that? The benefit is we can safely treat a patient in lower number of treatments with precision and higher dose. That's the beauty of it. So there is other names for it. There is SRS, stereotactic radiosurgery, SBRT, stereotactic body radiation therapy, SABR, stereotactic ablative radiation treatment, or extreme hypofractionation, or CyberKnife by itself. And what is CyberKnife? Again, is not a real knife. The reason it's called CyberKnife is a virtual one. It acts like a knife. The outcome of it is like you have surgery. That's the beauty of it, but doesn't have the toxicity of surgery. That's again, the beauty of it is. This is a system of delivering a high dose of radiation with a high degree of precision and accuracy. And that's the beauty of it. Again, more physics of it. You can read a 6 multi-voltage linear accelerator mounted on the computer controlled robot that uses a frameless. I'm not going to read the rest of it, but is it clear now, when we put some physics in there? So we go next. This is what it looks like. This is if you come to our center in Orange County at Orange Coast, this is what you see. It's a big arm, two arms, one arm that the patient is going to be on it that can move multiple degrees, and the arm that has the radiation source on top of it. So again, there is an accelerator on the top and there is a manipulators. As you see, this is an imaging system just to make sure the prostate is in the right place, the patient is in the right position. And the beauty of this arm is also follows the motion of the prostate. So it follows it, it makes sure if the patient moves, it stops treating, and also follows the prostate as well. So it pretty much locks on that target. So that's because it can move with it. okay? And this is the targeting software that it looks like. I say again, is locking into that fiducial marker, for example, in the lung. We can treat lung with it as well. Now, what is our process overview? Like what do we have to do to get the patient started on CyberKnife? So the first thing is a consultation. So you come in, you have a consultation. We see if you're a good candidate for CyberKnife or not. Again, we have multiple different ways of treating prostate cancer. And then after that, if you are a good candidate for CyberKnife treatment, we ask to put some fiducial markers, which is a small, very metal type fiducials that the urologist can ask urologists to be put on. If the urologist doesn't put on, then we can put it in as well. It doesn't hurt at all. It's just a one needle. One is about 3 needles inside the prostate. That's all it is. After that, we set the patient up for a MRI scan, because this is a very precise and accurate treatment. So we use the MRI and CT fusion to make sure that the treatment is very accurate and the definition of the target is very accurate. And then we use a planning system, treatment planning, to make sure that we have a great conformal treatment plan just to the prostate and nothing, no organs around it. The beauty of this technology is the adjacent normal structures doesn't get as much dose. Okay, and the uncertainty is very low, and that's why we can give a high dose per treatment. And then we get you going for the treatment, and then you follow up with us with the surveillance. And let's see if the video works. It's okay. Sometimes the video doesn't work. It shows actually how the CyberKnife actually image the prostate as we go, and it actually follows the prostate movement if we want to. Okay. All right, so what are the comparison between CyberKnife and other techniques? If you go to radiation oncology, they may discuss CyberKnife, HDR, LDR, which is high dose rate brachytherapy, low dose rate brachytherapy, which was the seeds, 3D conformal radiation treatment, or even proton therapy. And if you look at it, the beauty of CyberKnife is has a continual image guidance throughout the treatment. So make sure the target is very accurate and is locked on the target and is not invasive. So unlike brachytherapy, there's no needles inside your prostate. It's only 5 treatments. The other techniques has more than 5. Is about the lowest one that you can go is 20s and goes up to 44 to 48 treatments sometimes. It depends on what center you get treated with. Does not require anesthesia and does not require operative procedure. It's only 5 treatments and done. So it's really for patient convenience. That's the advantage of it. And patient convenience, 5 treatments only, you're done with it. Each treatment, you come in, they set you up, it takes about 45 minutes each treatment, and you will be done with it. Is against other treatment, which is 40 to 45 daily treatments. You have to come in over 8 to 9 weeks. So, it does the same thing, the same outcome, less toxicity. I will go over all of that in a minute. It has the image guidance throughout the treatment to make sure it's locked onto the target and it doesn't move, or the uncertainty is so low. And also it has a radiobiological advantages. We found out that if we can give a higher dose per fraction, there is a possibility of better outcome in prostate cancer patients. And with this technology, you can do that. And this is one of some of the plans that you can see with CyberKnife, that it looks like you can even pretty much replicate the treatment that you can give from the internal radiation from high dose rate brachytherapy, which is very conformal, and you can pretty much replicate that as well. And the beauty of it is not invasive, and the radiation coming from outside. So this is what does it look like? As you see, the arm can go multiple different angles, unlimited angles, and that's the reason you get a very conformal radiation plan. This is 130 non-coplanar beams that is going toward the prostate. And again, it's 5 treatments only. And this is some of the other pictures that I could show you regarding a plan of a CyberKnife in the prostate. As you see, no radiation dose anywhere else. Your hip doesn't get any much of a radiation dose. Your bladder doesn't get as much radiation dose. It's very conformal and precise. So what about the NCCN guideline? What is the NCCN guideline? Why do we follow it? So it's a National Comprehensive Cancer Network. Is one of the things that try to tell all of the oncologists that what is recommended based on the results, publication, outcomes. Okay. So it's literally a alliance of 25 large cancer centers, big cancer centers, that they sit down and they decide what is the good thing to do, what is the right thing to do, and what is the recommended treatment. And if you look at the guideline, the CyberKnife or radiosurgery is considered as a standard treatment option. So you can offer it to prostate cancer patients. We do have a lot of publication regarding this. We have a single institution, multiple single institution series that shows very good toxicity and great outcomes. We have a pooled analysis of phase 2 trials that again shows amazing biochemical relapse-free survival. And that's the reference. And also there is an ongoing phase 3, and also there's a phase 2 randomized trial that the interim analysis shows great GI, which is gastrointestinal and genitourinary toxicity after follow-up for about 36 months. And we're waiting for those results to come back. And the outcome also shows promising. Based on all of the data that presented and published, this is the table we can come up with. So if you look at it, the stereotactic body radiation treatment, which is the same as CyberKnife, has very low toxicity and it's excellent outcome, excellent disease-free survival. And again, it's very conformal. And again, more than 20,000 patients and men has been treated with CyberKnife thus far. And those are, again, all of the publications up to 2019. There is more publication came actually in 2020, a little bit more too. And again, who is the candidate for CyberKnife radiosurgery? Low and favorable intermediate risk patients with cancer that is not a spread. CyberKnife alone is an experienced center, is the best way to do it. For example, our center has been treating patients with CyberKnife for the last 10 years. Unfavorable intermediate and high-risk prostate cancer can also be treated with CyberKnife, mostly with the combination with the hormones and IMRT as a boost. You can treat recurrent prostate cancer with CyberKnife because this technology is very conformal. And also you can treat metastatic disease for palliation for brain and spine with CyberKnife radiosurgery. And there is a lot of trials that are undergoing. We do have a trial as well in Memorial Care Hospital, which is to do with the stereotactic body radiotherapy with CyberKnife or with other type of machines that looks at it as a monotherapy, which only have CyberKnife treatment or radiosurgery treatment versus boost treatment for higher risk patients. Currently enrolling a lot of patients into it. We treat patients on trial or off trial, but we do have this trial from a long time ago. We still keep it going and we're republishing soon on it. Again, we can treat patient on trial and we can treat patient off trial because of, again, the NCCN and all other publication showed evidence that this is now the standard of care for this treatment. So now, pretty much this was the last slide. But just the one last thing I want to say, because again, I was the director of the Proton Center in Michigan. The role of proton therapy in prostate cancer is interestingly not well defined. There is a randomized trial that is going at Harvard trying to look at the benefit of proton therapy versus photon therapy. Again, that's fractionated. That's like 40 treatments, daily treatments. And so far, they have not published it, but the interim analysis of other publications shows not much difference between proton therapy and other type of radiation treatment. But again, we have to wait for the randomized trial. Wow. At our center in Michigan, when I came from about 7 months ago, I moved to California now. We didn't treat as many prostate cancer in only 1 or 2 spots because, again, the benefit is not yet known. And to my experience, I treated a lot of patients with proton therapy at MGH, Harvard, and also at Beaumont. I don't see much difference between the photon or proton. But this is different. Radiosurgery, I think this is probably the future of the treatment of prostate cancer with radiation because it is low number of treatment and it's very precise and accurate treatment. Now, I want to open the floor for any questions.
Doctor, can you close your shared screen and I'll do gallery?
Okay.
Thank you.
Let's get into chat and see what kind of questions we have. We have a question from Mark. Is SBRT applicable for patients with large prostates greater than 100 cc's prior to TURPS or PAES?
You can use SBRT for larger prostate, but if you are getting TURBT because you have a lot of symptoms or urinary symptoms, we would like you to get the TURBT first before we give you the SBRT because As you know, radiation causes swelling of the prostate, and your urinary symptoms can get worsened during the radiation treatments. And if you already have a lot of symptoms for urination symptoms, then we would like you first relieve that symptom, make it better before we give you any type of radiation. Otherwise, again, we can give it to you, but we have to watch your symptoms. The prostate does get smaller after radiation treatment, but over time. Okay. Again, every patient comes into the consultation. We do evaluation and questionnaire, which is called IPSS, to look at the scoring system, what is the urinary symptoms are. And then we make a decision if you're a good candidate for SBRT or any type of radiation or not. But majority of the patient are candidates for SBRT.
Excellent. Do you think that SBRT will be given by Proton in the near future?
It can. Actually, I did have a publication on it. If you search my last name, you see prostate cancer and SBRT, prostate cancer SBRT with proton therapy. It can, but the problem is right now we are pretty far from it. I do have a patent based on the therapy of proton therapy with ARC. And if it comes out, we can treat prostate cancer with proton therapy. However, I have to say the benefit in comparison to CyberKnife or radiosurgery with photons is not as much difference. And that's the question. Because you still have to use multiple different beams for proton, and that's when you lose the concept and benefit of proton therapy, because proton therapy doesn't have any exit dose. So you want to use the least amount of fields. So right now, no. And in the future, even if we can, we have to use multi-field of proton therapy, and the benefit get lost as you compare it to radiosurgery with photon.
Okay, thank you. What is your opinion of SBRT for rising PSA after a radical prostatectomy? I assume what Dr. Metzger means is using this on the prostate bed.
So that's a very tricky question. Yes, have I done it before? Yes. But the thing is, we do make sure that you get an MRI scan, and most of the time I use it if I see something on the MRI, any residual or enhancing nodule. What I do treat your prostate bed and also boost that nodule to the higher dose. Is it a standard technique to use for prostate bed radiation, salvage radiation treatment? No, it's not in the NCCN guideline. It's not many publication on it. It has to be treated off trials or off studies or off protocol, because the treatment of that is external beam radiation treatment fractionated, and most of the time we give hormones based on the new RTUG publication recently.
Victor wants to know, how is the urethra protected during treatment of the entire prostate?
Very good question. So when we treat that, the beauty of it is because the plans are very conformal and we have a higher degree of decreasing the dose to anywhere we want. We actually draw, that's the reason you get a Foley at the time of mapping. We draw the urethra and we make dose. The dose to that urethra is below the constraints. And that's one of the things that if you want to get treated with this, you should get treated in experienced centers. Otherwise, they would not know how to contour the urethra or decrease the constraints to it. But we do. Yes, we make sure that we map you with a Foley on to exactly coordinate the urethra directions, and then we make sure that there is no max dose or anything on the urethra, so to decrease the toxicity of that.
Stephen Haymaker has a Highmaker. I want to put a Y at the end in Stephen's name. Haymaker has a question about space or gel, and some surgeons believe in it, and for others, maybe it's just a moneymaker. So get some views on the correct use of space or gel and the kinds of procedures you're talking about.
I think any new technology that comes out, you always have some people believe in it. You always have some people don't believe in it. And again, we give you an option. You can either choose it or not. But if you just use your own rationale, you will have some dose to your anterior rectal wall, which will cause can cause diarrhea or rectal bleeding. And now if you put a gel, it's not about the surgeon believing in it or not. It's about the radiation oncology is evaluating you believing in it or not. And radiation oncology, I promise you, will tell you that yes, the dose to the rectal wall will decrease, and that is based on publication will decrease the toxicity. And there is a randomized trial on this that is published about 3 years ago by Michigan that is already published and showed that decreased toxicity if you use hydrogen. And the person that published it is Daniel Hamstra, Hamstra. Right now, he's the chair at one of the institutions in Texas. He was in University of Michigan, then he came to Beaumont, then he's now the chair at Baylor, radiation oncology.
Outstanding. Fred wants to know, what is the cost of CyberKnife? Is the cost of CyberKnife similar to the external beam or brachytherapy? Is it, and second part of the question, is it covered by Medicare?
So the last answer of that question, I know, yes, it is covered by Medicare. The first portion of the question, I don't know much about, because it's always is covered by the insurance. We don't treat patients if they're not covered by insurance unless the patient wants to pay out of pocket. But when I looked at the data out there, as much as I know, it is very similar. The S3 active body radiotherapy has a similar cost to the other ones, because you get 40 treatment of the other one or 30 treatment on the other one, and this is only 5 treatment, but the cost for every treatment is much higher because it's very specialized, precise, and accurate treatment. But if you're asking which one is higher, which one is lower, I don't know. I have to look that up because I don't look at the, I only see the patient and treat them. And majority of them, again, we wait for the insurance to approve. Medicare is the best insurance. They approve everything. All of these are approved.
Okay. I'm going to start, Joseph, with the end of your question and work up to your case history. What are the success rates of CyberKnife on metastatic cancer to extremely small cancer nodes? And this is Joseph's history. I had a radical prostatectomy in 2019. Cancer had metastasized before I was diagnosed, so PSA after surgery went from 0.3 to 0.6. I had radiation therapy to the prostate bed after 8 weeks, but I still had a 0.6 PSA. After 3 PET scans, I had PSMA PET, which hit 2 pelvic lymph nodes, had CyberKnife radiation in April, and waiting for my first PSA following that CyberKnife radiation.
Munch?
Yeah.
Good. Okay.
So the answer to the question that if you go to different centers, they treat you differently. I mean, some people can use CyberKnife for, if you're asking if there is publication on that, there is very, very low number of publication regarding the benefit or the success of CyberKnife in treating the lymph nodes. It will get rid of those 2 lymph nodes. I promise you that the CyberKnife will get rid of those 2 lymph nodes that was positive. Now, the question is, some people, including myself, believe that if your lymph node is positive and it was not treated with radiation in the past. So again, I don't know when you had radiation to your prostate bed, did they include your lymph node regions or not? If they did not, then sometimes the physicians are believe, how did the cancer got into your lymph nodes? So if we treat those only 2 lymph nodes, what about the lymph nodes around it? So the thought is maybe we should treat the whole lymph node chain and then boost the lymph node alone. Or some people believe that, hey, we're gonna go treat these 2 separate lymph nodes to make sure they're gone. And then if anything else pop up, we treat it again. So which group is correct or right? We don't know. Is there any publication comparing the 2 groups? No. Which one? Both of them gonna have success, but again, it's just different thoughts, physician thoughts that again, this is something that is rare, that is out of ordinary, that we don't see a lot out there. So.
Okay. If Joseph, if you want, you could post a follow-up question. Steve wants to know, what is the cure rate for low risk prostate cancer with CyberKnife? I'm guessing when by low risk you mean just Gleason 3+3. Can other treatments be used if CyberKnife is not successful or in cases of metastasis?
So, first of all, the success of the treatment of CyberKnife treatment for low-risk prostate cancer, which is again a Gleason score 6 or lower, PSA 10 or lower, and the state which is again less than not, you can't feel the nodules or anything like that. Those are the success rate for that is in 90s. One publication is 94%, and we have some at 96%, so it's in 90s the success rate. So it's very good success with CyberKnife radiosurgery for low risk prostate cancer. Now, the second question, if you do get CyberKnife and it's not successful, what else can you get? You can always retreat with CyberKnife, or you can also treat with other ways, which is surgery is another option. You can also do hormonal treatment, a systemic treatment, and the other options that are out there, that HIFU or anything like that, which is not, the evidence is mostly based on the primary treatment. Can you get proton therapy? Sure, proton therapy can be another option if you already got CyberKnife and you did not get things. But again, majority of the time, you have to be careful. If you already got radiation treatment, re-radiation can cause a lot of toxicity. And again, there are only very limited publication out there.
All right. GK wants to know what advantages, if any, is there for CyberKnife RT for sacrum metastasis?
So we treat a lot of bone metastasis with CyberKnife. Especially there's so many trials out there that showed benefit radiosurgery to bone metastasis, especially in the setting of oligometastatic disease. This is based on the COMET trial, C-O-M-E-T trial, that any patient with oligometastatic disease, they would benefit from treating the bone lesions with CyberKnife or radiosurgery. And there is also another trial that showed if patient presents with metastatic prostate cancer, with oligometastatic disease, there's a benefit to treat not just the oligometastatic or metastatic sites, also treat the prostate as well. It showed benefit in outcome. So yes, we do, is very successful. It depends on how big the lesion is and how much dose, and also the critical organs around it. So if we're not constrained by those factors, then the rate of control is very high, nice. It can be nice. It depends on how big the lesion is and how much we are limited based on the adjacent organs.
Excellent. Ira has a multi-part question. The first is, do you suggest getting treatment daily or every other day? That's part one. Part two, how many grays? Why is that? And the third is, does it make much difference in grays between 35 and 40?
Very good question. So you're very educated on prostate SBRT. So what was the first one? The first portion of the question was,
do you suggest getting treatment daily or every other day?
So majority of studies are every other day. We treat patients every other day because we want to limit the toxicity. There are some studies out there, not on prostate, on radiosurgery, on other sites of the body, that shows a little bit of higher toxicity if you get treated with daily treatment. So we do treat in our center as every other day, and because of the majority of the published data is based on every other day. But can you do it daily? You can. But majority of the publication every other day, and that's what we follow. We follow evidence-based medicine. Number two question is, what is the dose? So for the low-risk prostate cancer, it depends on what kind of low-risk prostate cancer or not, but original trials are based on 36 gray or higher in 5 fractions. There are there are a couple of them based on 35 gray. We do, again, it depends on what risk factor we're treating, but for low risk, the current publication shows that we do not need more than about 36.25 gray in 5 fraction to have a great outcome. Is there a benefit of going higher dose for low risk prostate cancer? The publication out there did not show benefit, and we don't want to cause more toxicity. So why should I take it out there, right? But if you have, for example, intermediate prostate cancer, sometimes we do go higher than 36 gray or 36.25 gray to even up to 40 gray, because those are, again, more aggressive cancer, and we want to have a higher dose to control it. Is there a study that shows the difference between the two in intermediate risk or prostate cancer that is published? Is only institutional? But nowadays, if you go to MD Anderson, MGH, or UPMC, or all those places, sometimes for the intermediate risk prostate cancer, they do offer about close to 38 to 40 gray to the prostate itself. And again, it's a very complicated way of doing it. It's called dose painting. Again, you can do it with CyberKnife.
Okay. Victor Ortiz has a question. What evidence is there to support the abscopal effect, e.g. for the limited lymph node question? And if I didn't ask that right, Victor, unmute and we'll let you ask that question.
So abscopal effect is to do with immunotherapy. So there is a, when I was in last year of residency, there was a publication on abscopal effect saying that radiation treatment can hype up the immune system. So when the medical oncology give immunotherapy, there is a better and synergistic effect of that radiotherapy causing an immune system to kill the cancer cells by the immunotherapy, but your immune system yourself. Is there data on prostate cancer? How much data is very limited on abscopal effect and CyberKnife and radiosurgery and immunotherapy. Very, very, very limited data. That's a very new topic and things that there's a lot of research undergoing right now.
Excellent. Maury wants to know how appropriate is CyberKnife for sclerotic prostate cancer in the thoracic spine?
So again, that's the bone metastasis. Majority of the prostate cancer bony metastasis all is sclerotic, and again, it is if you have lytic or you have a sclerotic. So prostate cancer bone metastasis is sclerotic, and the treatment is successful with radiosurgery. Again, it depends on what factors are we limited. Are we limited to the adjacent organ, which is in your case would be spinal cord, and also how big the lesion is.
Okay. Ira wants to know, when you deliver, can you direct more radiation to the perimeter of the prostate for more aggressive cancers?
Yes, and that's what we were talking about nowadays. If we know where the, for example, nodules are or the lesions are, or even just the prostate itself, we can dose paint and higher dose to that area. Yes.
Outstanding. While we kind of have a pause in the questions, I kind of want to introduce the officers, the directors and advisors here, starting with Dave Lehman on the controls, both our Chief Financial Officer and our Chief Technology Officer. Dr. Charles Metzger is with us, is our advisor, and comes up with our wonderful newsletter on the latest and the greatest in prostate cancer detection and treatment. Maury's here, Maury Hartman, who leads our advanced diagnosed group and helps out with the newly diagnosed group. Ira is our advisor on and also leads our newly diagnosed group that Maury helps out with. It looks like Jim Bothwell's out there. Jim is our treasurer. Carolyn Adamson, and I bet Carolyn is sitting with Steve right now. Both are advisors. And I'm Neil Burke. I'm the Chief Executive Officer and also VP of External Affairs for Prostate Forum. And we got another question. Ira wants to know, how does SBRT compare with combination brachytherapy and IMRT?
That's a very good question. So there is a new trial that was published about 3 or 4 years ago in high-risk prostate cancer or unfavorable intermediate risk prostate cancer that showed that IMRT followed by HDR, which is high dose rate brachytherapy boost, is more beneficial rather than brachytherapy by itself, or rather than just external beam radiation treatment by itself. And how does it compare? That's the beauty of it, because we do have a trial and we believe that we can do the same thing with SBRT and using CyberKnife in comparison to HDR boost. So we do have a trial. I have treated patients on our trial, that we do IMRT followed by SBRT boost, the same way as the trial that was published, which is IMRT followed by high dose rate brachytherapy boost. We are actually right now working on publishing our first results. Again, it does look very promising and look similar to what it was published. Again, but we have to wait to analyze the full data, and then before publication, we need to follow the patient more.
Okay, Dr. Metzger wants to know, the question is hormone therapy before SORT.
Before, I'm sorry?
Before SORT, did I get that right, doctor? Hormone
Oh.
therapy before so. There you are.
What is SORT stand
Did
for?
it, SBRT, I hit the wrong button.
SBRT. Okay.
Okay.
It corrected your spelling and it shouldn't have.
Yeah, I having a little trouble with these fingers and the typing, but we used to use hormone therapy before regular radiation and always thought it may have some advantage. Is that true with SBRT?
Yeah, the same concept is going, especially at Sloan Kettering. They right now is doing it, especially on trials and off trials, and they use it as the same way. It depends on the risk factors. So low risk patient doesn't need hormones. Intermediate risk, favorable intermediate risk. The benefit of hormone is there, but it's limited. Unfavorable intermediate risk. Those are the ones that would benefit from hormonal treatment. And that's again, if they want to pursue SBRT, then you start hormonal treatment about 2 months or even at the same time of the SBRT, and you continue it for a short time hormonal treatment.
Yeah. By the way, thank you very much for taking the time. A very, very concise and easy to understand explanation. SBRT, it's just unfortunate they called it CyberKnife because all the surgeons and all got, irritated and
Yeah.
You know what I mean?
It is. I mean, nowadays we can actually give SBRT with other machines as well, which we do have, which is called TrueBeam Edge, all those things. But again, the CyberKnife, the beauty of it is you still get a little bit of plan than the other ones. This is the beauty of it.
Is there still one in Pasadena?
I'm sorry?
Is there still a unit in Pasadena?
I do not know. Our unit is in Orange Coast.
Yeah.
But we do have the other unit, other type of units can deliver the same thing in Saddleback and also in Long Beach. One is called TrueBeam, one is called Edge. But CyberKnife is only one in our system, which is in Orange Coast.
Yeah, they're really pushing it at UCLA.
Right.
It's really something.
Yeah, but it's not CyberKnife at UCLA. It's a different machine that delivers.
Yeah, actually, they have two of them, but that's okay.
Yeah.
All right.
By the way, can I ask a question?
Sure.
For the IMRT, how many in that study? How many sessions are there after the SBRT?
Well, before, we normally give this SBRT afterward, but normally is about 25 sessions.
Oh, 25?
Is about 25. So it depends again, but if we cover your lymph node or we're not covering your lymph node, but normally we can do it in 25 sessions or 28 sessions. It just depends what, but normally, 45 grade to the pelvis and the prostate, followed by SBRT boost.
Thank you.
Okay. Let's take a look at Michael's question. When can we expect the trial on CyberKnife and localized prostate cancer to be published?
Only the interim analysis is out based on the phase 3 study. That's the one that there are two actually trials going. There are multiple actually. The two that are advancing, there is a phase 2 study and there is a phase 3 study. Two different studies. The phase 3 interim analysis on toxicity, which I showed this slide, showed pretty promising, very good promising toxicity, but the main results, not out yet. So we're waiting for those results to be out. Probably soon.
Outstanding. Does anyone else have any more questions? Doctor, I want to thank you for joining us on such short notice. And thank you for just a wonderful presentation. And we're looking forward to having you back again.
Thank you very much for inviting me. Thank you.
Anyone else before we sign off?
So to everyone out there, am I being heard? Dave Lehman here. I'll do my best. There's processing time to once this Zoom session ends, and I'll make my best to get it onto YouTube by tomorrow. So thank you, Doctor, and we appreciate your presentation. Very informative. So thank you.
Thank you very much. Have a good night.
And we look forward to having you back again. Join us, please.
Sure.
I
enjoyed
it. Have a great rest of the month. Enjoy the 4th of July, folks, and we'll see you back here again on Thursday at 7 o'clock Pacific Daylight Time.
Thank you very much.
Okay, we're all done.